Hi, Dr. DiSibio. You're the host now, just so you know. You're muted, by the way.
I'm not muted now, right?
Right.
Okay, let me pull up my presentation. How's that look? Are you seeing it?
Yeah.
Okay. Let me make sure I'm clear. Did Dr. Malhotra say he needed a little bit of time, like 5 minutes or so?
I'm not sure. Let me check.
Okay.
Yeah, he asked you to set aside 5 minutes beforehand so he and Dr. Yang could give a little talk.
Okay. He's not on the session yet, I take it, right?
Right.
Okay.
I believe he just connected.
Okay. Hi, Ashim.
Good morning. How are you?
Oh, you're not muted. Okay.
Thank you very much, Guy, for doing this. I really appreciate it.
Good. It's a good time to get this out there.
Yes,
I hope
awesome.
it'll make things more clear for people who are going to be helping too. So we'll see.
Yeah, that'll be great. I think it's a wonderful opportunity. This is a very important initiative. Can you hear me?
Yeah, I can hear you very well. Are you in
good.
your office or are you at home?
Yes, I'm not in my office. It's
Okay.
here to conduct things.
I'm recognizing the background. You're either
Oh.
very business-like at home or you're in your office.
That's right. All right, I'm going to go ahead and
go.
myself, and I'll be back in a few moments.
Sure. Okay.
Guy, good luck.
Oh, hi, Joe. Thank you. I hope it's clear.
It'll be clear. I'm going to go off recording. Since we're not usual doing this, maybe periodically you should just say, we're going to arbitrarily set point in 5 minutes.
Okay.
Does that give you enough time?
The full hour. I think I get an hour total time. It
Right.
sounds like Ashim wanted to have the first 5 minutes to say something. I'm not sure.
Who did?
Dr. Malhotra.
Oh, okay, that's fine.
Yeah, he was
Good.
just on the line. So
Yeah, that's fine. I'll stay out of the way. You guys got it all planned.
I'll go ahead and defer. Yeah.
Okay, good. I'll put you on silent mode. Me on silent mode.
Wow, we've already got 13 people. I'm impressed.
Good morning, Dr. Silva. If you want to say something, Dean Silva, of course, you're more than welcome.
Yeah, absolutely. I'm just hoping people will unmute themselves and shout out questions because it's kind of hard to.
Yeah, that's what I wanted to help navigate.
Yeah, great. Thank you. It's hard otherwise to keep my eye on the chat box and the presentation at the same time. So, but go ahead and start talking whenever you like, Ashim. I'll let you run the show at this point.
Okay, I think it's 12 now and all my electronic devices, so at least I'm timed correctly.
Yeah, mine too.
Good afternoon, everyone. I'd like to welcome all of you to this first of a kind for the Institute of Teaching and Learning Excellence, the first of a kind distance education, distance learning, faculty development, and professional forum. First of all, I would like to, at the very beginning, request that for anyone who is not currently speaking, if they could please turn themselves to mute, that would help reduce any kind of echo that might occur. And I don't actually understand the mystery of this whole echoing because we're not even close to each other, but still, sometimes the echo, the reverberation is really quite irritating. So as Dr. DiSibio starts his presentation, perhaps we can go ahead and keep ourselves muted, and we will build time for people to ask questions towards the end of the presentation. I'd like to also remind you that there is a chat box that Samantha Webster, who works in the Office of the Vice President of Academic Affairs, she and I will be monitoring throughout Dr. DiSibio's talk. In case you have any questions that you would like to share in the chat, we welcome you to do that as well. But as I mentioned, Dr. DiSibio will have some time towards the end for questions. So at this time, I'm seeing many of you after such a long time. I see a lot of my colleagues and friends are on here. Salah, welcome. Tariq is here. So many friends and colleagues are here after such a difficult and ghastly 4 months. So at the very beginning, I'd like to welcome all of you to this session for the ITLE. I think it's a little unfortunate that what's going on in the outside world and where we are today. So I'm sure that you will all join me in sending your best wishes to all of our communities that we serve together as healthcare professions. I'm also sure that you would join me in congratulating and thanking all the various stalwarts, the heroes, our pioneers, who are actually our students, our faculty and staff, who are out there at the front of the lines and for whom this is a very, very real pandemic, and who are working every single day to make the lives of everyone better. At the same time, I think the ITLE is playing almost an insignificant, a very small role in trying to help with training our faculty, continuing our professional development programs so that our faculty can provide the best of this training to our students. So a ton of gratitude to everyone for all the work that is ongoing. So at this time, I'm going to go ahead and talk a little bit about some of the things that the ITLE has planned, and then I'll turn the podium over to Dr. Catherine Yang. I think I should have started with this, but I think at this point, most people know me. So for anyone who does not know me, my name is Ashim Malhotra. I'm a College of Pharmacy Associate Professor, and I'm the director of the Institute for Teaching and Learning Excellence. And the Institute for Teaching and Learning Excellence, or ITLE, as I like to call it lovingly, is actually placed in the Office of the Vice President of Academic Affairs at CNU, and that is Dr. Catherine Yang. So very quickly, I won't take a lot of time away from Guy. Couple of things, like you were saying today, we have a presentation by Dr. DiSibio, which was originally intended for the spring session. We're also planning to have other faculty development workshops within the next month or so. We are hoping to invite back some of the other speakers for spring. So Dr. Puglisi might be on again in such a similar forum. We're also planning on working together with Dr. Ruth Final and restarting that research workshop initiative that is ongoing. Dr. Yang and I are working together to sort of also perhaps look at other mechanisms, such as other training programs for specific faculty for distance education, which obviously now is a prominent thing at all colleges and universities. And we're also planning a little bit about some of the teaching awards. Finally, ITLE is planning a retreat sometime in August, and we will keep everyone updated about that. So with that, I'm sorry if I stole away a lot of thunder from Guy. I'm going to now request Dr. Catherine Yang to please say a few words about where we are today. Dr. Yang.
Thank you, Dr. Malhotra. First, welcome everyone, and I'm very happy to see so many of you still active working on the academics. And I think during the pandemic, I'm very grateful that many of you actually so quickly overnight turn into online teaching masters. And that's just unbelievable. And you overcome a lot of hurdles, technical difficulties, but you step up as a suddenly star professors. You all made our students complete their courses, and we graduate very successful 2020 classes. So students are also very grateful for our professors teaching, and I heard a lot of positive things because I collect all the surveys, and I'm just very, very grateful what you have achieved and what you have done for the programs and for the universities. And Italy, I have to attribute all the credit to the leadership led by Dr. Malhotra. All last year, we had promoted a lot of programs, faculty development programs, and we probably never expect this pandemic would come, but the pioneer the training for the online teaching, give faculty some previews of how online teaching would look like. I think I'm very grateful for all the Italy members were able to lead programs, faculty learning community programs, and general faculty developmental programs. And I'm very happy to see the faculties who showed enthusiasm to share their teaching experience with all the peers. And then some of the faculty are also willing to participate, advance themselves. And I'm glad that Italy served as such a faculty like hub that together we have the same mission to advance our education mission here. So I thank all the Italy members and also the faculty participants and the speakers, and plus award-winning faculties that last year for the recipients. Plus, we also granted many grants to the pedagogy programs, and I want to appreciate all those active faculties, no matter how difficult the situation is, and you don't maintain a strong passion and commitment to our advancement of the education benefiting our students. So without too much delay, and I want to appreciate today, Dr. DiSibio actually gonna give us his scholarly work being continued for a while about the electronic health record at the CNU-COM teaching paradigm, and I appreciate his continued effort in his scholarly field. Okay, without further, and I hope everyone enjoyed today's talk.
Dear Dr. Yang, thank you very much for your words of wisdom. I'm going to go ahead and briefly introduce Dr. DiSibio, and I'd like to welcome President Chung. This is a very fortunate moment that he's found some time. Thank you very much for being here, sir. Thank you. So Dr. DiSibio, a few quick words about my wonderful colleague today, and thank you very much, Dr. DiSibio. It's a privilege to welcome you, and it's a privilege to have you talk about this. Dr. DiSibio joined the faculty of California North State University College of Medicine as an associate professor with the arrival of the first matriculating class in 2015. Dr. DiSibio earned his MD and PhD at UCLA in 2003 and pursued postgraduate training at Stanford and Harbor UCLA medical centers. He subsequently earned fellowship degrees in hematopathology and molecular genetic pathology at Cedars-Sinai and Montefiore Medical Centers. We're very, very proud, Dr. DiSibio, to welcome you. It's your show. As a quick reminder, everyone, if you could please mute your mics at this time, and we will be monitoring the chat in case you have any questions. Thank you.
Thank you, Dr. Malhotra. I hope I get this all technically correct. First of all, everyone can hear me, correct? And can see my presentation.
Yes.
Yes, I'd like to thank you, Dr. Malhotra, for giving me the opportunity to discuss our teaching paradigm that we are developing at CNU, which revolves around the electronic health record. Over the course of the talk, I'd like to begin by just highlighting some of the history of the electronic medical record. And in so doing, I hope begin to explain some of the rationale for introducing the EMR as an actual platform for our undergraduate medical education here at CNU. I'd like to speak a little bit about how we've designed our platform and some of the features we considered in trying to optimize the platform over the course of the last couple of years. I'd like to describe a typical EMR session, and importantly, I really want to leave a little time to invite your questions and or suggestions as we go forward with this platform. So on that note, we're all, of course, familiar with the EMR, whether we have seen it as we go into our own doctors or whether we use it in practice. And I think it's always kind of felt like something of sort of a recent invention, but in fact, it probably goes back a little more than 50 years to the time that it was first conceived by some big corporations like Lockheed Aerospace, and ultimately the Veterans Administration and Kaiser. Lockheed, in fact, formalized it in 1971. So they had a big patient base, they had a big employee base, and they were trying to figure out the most efficient and clean and reproducible way of keeping track of their employees. If we fast forward to the year 2008, when, of course, the housing crisis occurred, and the government instituted something that was called the American Recovery and Reinvestment Act. In the course of formulating that legislation, they realized, members of the Obama administration realized that we have a lot of tools that we could be using to make our record keeping more clear and transparent. And there should really be no reason for things to happen like our housing bubble. One of the targets of that legislation, of course, was the electronic, medical record keeping in general, transfer of files. And so the electronic medical record came up as something that had been kind of gestating along at that point for many years, but had never really been formalized or developed to the extent that they thought it could. The next iteration, of course, was turning things from just flat records of people's office visits into something called meaningful use, which was kind of the next iteration of computer capability, perhaps to the point of having the computer keep track of people with diabetes or chronic conditions, for example, send out records, and in that way help doctors kind of really improve their efficiency, their efficacy, and their safety in patient care. As of about the year 2015, of course, what had been sort of gentle reminders of how electronic health record keeping could improve practices, the government kind of went from the carrot to the stick, saying that in fact, if you don't have an electronic health record, we're going to start taking away Medicare reimbursement. So, of course, as of the more recent years, we're up to like the high 90s percentile in terms of usage of electronic medical records. Very few practices still just do things on paper. As of this year, there are about 1,100 companies, in fact, now developing EMR platforms. So we've all been very familiar with very popular platforms like Epic and Cerner, but one can really only imagine the level of complexity now that EMR has adopted. And so really the question becomes one of how can doctors and physicians in training learn to use EMR to the best advantage? And what's the best time to begin their training? Well, our hypothesis and that of others, including the AMA, really is the most optimal time is probably while our students are in their undergraduate training. And I hope that over the course of the talk, you will come to share that, that opinion. So this is an all too familiar picture for those of us who have been through medical school. This is, what the first day of coming into the clinics looks like. And I can certainly relate to this person. I can also relate to her jealousy for this person. So there's, of these two people, one of them has probably been fortunate enough to have gotten some insight into what their very near future is going to look like. So our hope is to educate our students to be sort of a hybrid between the two, right? So someone who has probably a realistic concern for the kind of the enormity of the task of taking care of patients, because of course they've left the relative tranquility of the first couple of years, and now they're moving on to something that's a little bit more messy and less well-defined, which is of course taking care of real patients. Now the question becomes one of how we can help facilitate the transition. And so we began to ask some questions of really, how can we do this? And, before we jump into the deep end of the pool, do we have a good audience, in our students right now for introducing an education through EMR training? Well, gratifyingly, of course, overwhelmingly the students did look to this as a more interesting, perhaps, way of preparing themselves for their coming clinical training. And you can see, of course, here in red, this person, I think, realistically thought that this is going to be sort of an overwhelming task. This person, of course, who wrote in all caps, already was insightful enough to think, why can't we incorporate this into our medical skills training, which I'll describe in a minute. Going along, we also asked in surveys, what kind of a background do our students have? Number one question being, what have you seen from electronic medical charting, for example? And you can see that of the students who answered this survey, it seemed like really the majority has probably done something in the medical record, whether they worked as a scribe or whether they're more directly involved, for example, as an EMT. Most students, and of course, as no surprise, ours have been raised in an era of a lot of electronic and digital media use. They're probably well poised to begin incorporating this into the rest of their medical training. We also wanted to query our preceptors. Obviously our students are going to be going in a lot of clinical practice sites. But the question is, how receptive will our preceptors be to our students wanting to use the medical record in their daily training. Happily, it looks like it's really only the minority of our preceptors who anticipate not allowing our students any kind of use of the electronic medical record. They may have some kind of a hybrid or like a written document in mind, but it looks like, fortunately, a lot. So quote a lot. I'll talk about what that means in the next slide. Want to see our students having a lot of use of the electronic medical record, and you can read some of their comments. Some of them really just want the students to look, but not type in any notes or do any selecting of any kind of lab use or anything. We'll talk a little bit in a minute about what that means. But you see some, on the other hand, want students to have access for every one of their patients, certainly the ones that they're going to be caring for. All right, as I said, you know, if we look, only a small minority of preceptors actively don't want students necessarily to come in with training. They anticipate having students receive any training that they will require before they actually get to the site or in conjunction with the site itself. Others, it looks like almost 90%, really want the students to be pretty adept with going through the EMR and at least giving them a good chart review, the preceptor or the team, about the background of the patients so that they can perform as part of the team in the workflow. But we think all of these findings were quite encouraging and really in conjunction with our hope to give some additional training to the students before they get into the clinic. Now, here are some survey feedback questions. I just wanted to point out some of the things that I've highlighted. You know, not surprisingly, some of the preceptors do have some concerns. They wonder how to really integrate electronic medical record charting with actually teaching the art here of medicine. They are particularly dubious about allowing students to get in the mindset of using so-called templates. So people who've used the EMR probably know there's things like you type in .normal exam and a completely normal exam is filled out in your note, which is a nice thing if you're working very quickly, but mistakes do happen. And especially when the students are in training, we might be a little thoughtful before we allow them or encourage them to use tools like that. Moving on, we began to think about, it seems like we have a fairly receptive audience amongst the students and the preceptors alike. What would be a good time to segue in some kind of an EMR platform, and I'll describe that in the next several slides, within the first couple of years of medical school education and training. People who teach at or have visited our school will of course recognize that the elements of our first and second year are really kind of laid out like this. So we, both years of course involve a lot of classroom training, and I've just designated those as basic science lectures here. We also integrate a weekly, what we call a clinical case. So those are cases where students work in groups with a prototypical patient with a prototypical problem, maybe more easily said. And then they developed that case. They learned to pick important clues out from a patient's presentation that give them some sort of actionable items to follow in caring for that patient, in coming up with a management plan, in developing a differential diagnosis. Also integrated into the week is their medical skills training. So whether it's first year or second year, they're getting more and more emphasis on their clue gathering skills and their ability to document and articulate their thoughts in a written note. So this would be the first year. As we move to the second year, of course, the structure is quite a bit the same. But now thinking along to the MS3, which will be closely following the second year, we have begun to design a set of EMR exercises, and we have slowly introduced this over the last couple of years. And I just wanted to introduce over the next several slides what these scenarios look like. But first, our approach has really been that I wanted to emphasize. We've designed an EMR platform, which is a sort of a simple-minded version of more complex platforms like Epic and Cerner. And while, of course, we have the computer here as an important tool in the EMR, we also try to emphasize in our curriculum the importance, of course, of continuing the skills they've learned during MS1 of patient interaction. But more, as I just said, they're now right in the cusp of actually seeing real patients. So we want to make sure we emphasize the importance of coming to the exam room with a set of questions you are going to develop. These being the hypotheses that you are generating and the evidence that you're gathering to either reinforce or reject some of these different hypotheses. So we have, of course, developed an EMR platform that I'm going to speak about. We've tried to emphasize making it adaptable to a lot of different patient scenarios. We wanted to add some functionality, and I'll underline this word. My concern has always been that, if you throw students right in front of an EMR, they're going to probably quickly feel overwhelmed with what lies ahead of them. So we wanted them to, over time, understand some of the functionality of EMR and what it allows you to do without overwhelming them with just a kind of an overwhelming system. We've designed several different scenarios for different blocks. I mentioned earlier that the students are spending a lot of time in class. So they're learning about different organ systems, and they're learning to recognize clues and labs and examinations that they might want to do to highlight or follow hypotheses for those different scenarios. Our EMR, as I'm going to also show you, will give the advantage of being able to provide some feedback to students that we are designing to be more quantitative and measurable than they might be able to get just by, say, plunking in things into another simulation of EMR than what we are trying to offer. We also, as I said, want to segue this into a teaching environment that they are getting more and more familiar with over the course of their time at CNU. And that would be medical skills, of course. So we have incorporated standardized patients into our EMR sessions. We're having our sessions overseen by individual preceptors. And we have worked out a format such that students are able to work in groups of 3 or 4. And we use that as an advantage, actually, because as they're working with the EMR, they're also bouncing ideas off of one another, and we hope kind of reinforcing some of their medical knowledge in a way that will ultimately, when they do wind up working on their own, one-on-one with a patient and one-on-one with their computer, they'll feel a little bit more confident in their approach. We're using a platform. Dr. Puglisi was familiar with this platform, so he recommended we started using it. it is called LabVIEW, and the advantage of using LabVIEW, I'm not going to pretend I would be able to necessarily design anything on LabVIEW, but what you can see is that it's adaptable, and we can add elements as we see fit. Okay, so anyway, this is just a one quick snapshot of LabVIEW to let you know where we designed our EMR. So I'd like to go through a typical session, and in fact, this is one that we have gone through with the students. I'm sorry.
Good. You are good, buddy.
Oh,
Good
there we
guy.
go. So I got a round of applause there. That was Dr. Puglisi. Okay, let's talk about a typical session. So our paradigm is basically one that we feel a lot of the students are going to be seeing, whether they're in clinics or whether they're on the ward. We start basically with an established patient who has a documented H&P in the EMR. The students then will kind of work through what that patient's current complaint is, and use the skills that they have learned in their medical skills to ultimately develop their own contribution to that patient's care. That, as I will go through in a bit, you'll see it will entail ultimately writing a SOAP note to follow that patient. And the advantage then will be that they can get fairly immediate feedback on the labs they've ordered, on the consults they've ordered, and ultimately on their care for the patient. They will then follow everything with a documented any revision or modification of the plan as an addendum to that plan, and then they will go through with their patient. Okay. So here's our group of 4 students. Now, mind you, they're not in the room with the patient yet, but we have one, what we'll call a recorder, who is starting to pull together the documentation and the hypotheses about what's going on with that patient here. So here will be the first thing that student will do. He or she will pull up the electronic medical record, will sign in, and at that point on, of course, that student's work and that student's whole group's work is documented in the EMR. So this allows us a record that we can follow, and we can see how our students are doing and how they're progressing. Things like how efficiently and quickly they're working through their encounters, for example, is something that we will be able to follow. So, for example, we pull up our first patient, a gentleman named Ramon Molina. We see here his cover sheet. We see he's a 79-year-old male. We can see that he has fairly stable vital signs, a little bit of a low BMI. But you can also see here what Dr. Puglisi has designed in. You can see these are tabs that look a lot like what students will see in EPIC, for example. It's not an overwhelming number, but they are important functions, and we'll go through as we go through the next set of slides. So at this point, the students need to understand, before they even walk in the room and see their patient, they want to understand why their patient's there, and at least begin to develop some preliminary hypotheses about what could be going on with this patient. Importantly, what is actionable, I call it actionable for this patient, things that we can measure while the person's in the room, things that we can advise the patient to do or not to do before the end of the visit, etc. So here we are. This is their next task. They're going to go through the previous documentation. So they pull up the nursing note. This is the person, our nurse is, of course, the person who first intook this person and has documented a triage note. So let's take a look. Well, the first thing we notice about this gentleman, again, his vital signs look fairly stable. His chief complaint is falling. So that's why he's here, at least in as much as what he's told our nurse. We might also start to notice some interesting things. He's generally well appearing, he's well nourished. He also wears glasses. So we're starting to formulate some reasons. Remember, this guy is falling. We also want to document some other things from his past history. So we might look in his physician note. As I said, these are established patients. If we're on the ward, they have an intake H&P. If they're in the office, they had an H&P. So let's go take a look at that. And without reading through the whole thing, we're starting to scroll through his H&P. So we might notice a few things about this gentleman. We notice, for example, he has high blood pressure. He's taking hydrochlorothiazide. He also has a dyslipidemia, so he's taking his torvastatin. He has benign prostate hypertrophy, for which he's taking tamulocin, which is also known as Flomax. So we might begin to think a few things, what might be going on? We've not even entered the room. We go back here again. We have a tab, for example, for his medication. So we can see what he's on and when that was, what dose, and when the medication was started. So here we are back with our students. They've not entered the room yet, but they've now noticed that, I'm sorry, he's 79, but that's a little mistake. He is on medication for hypertension. He has hypercholesterolemia, and he's complaining of falling. Important, we think, at least as far as what he's told our nurse, that he's been falling. We know it. He's also taking an alpha blocker. So we might think about orthostatic hypotension because that is a known side effect of alpha blockers. He wears glasses, and at his age, we might think about maybe they're not the right prescription. We might want to check his acuity. He's also been complaining of trauma. For a gentleman this age, we don't want him to leave our office until we've checked him for some important signs, like, has he had any trauma to his head? Do we have any sign of bleeding? So this has all been done independently by our students. None of this has been fed to them. They're making their own hypotheses, and now we think they're ready to come in and meet the patient. So at this point, their next task is going to be to introduce themselves, make sure that it's okay with the patient, that they're writing in the chart, in an electronic chart, and think about performing their physical exam, which has to be targeted and very efficient. Start writing their SOAP note about what they're going to be finding. So here we are in our encounter. Now our green person is our preceptor. Again, our recorders here. And we have all of our students. There's 4 students total because that is how our groups have been designated. We have the advantage with our setup right now of having a designee be the recorder. Having this one, for example, be essentially the central figure who's going to be questioning the student, the preceptor, and suggesting findings or other questions to the other members of the group. These 2 are our physical examiners. So back to our patient, his chart, Our recorder can now log into the physician note and start writing his or her own note. And that will be in the format, as I said, of a SOAP note. They have, by this point, our students should be pretty well versed in what the elements of a SOAP note and really what the purpose of a SOAP note are. I would like to just emphasize that we want them to be coming up with very important and relevant findings, and also be thinking to the end of their encounter when their preceptors, when they're actually out in the clinics, are going to want to see, okay, very nice. What do you want us to, what do you suggest we do now? Okay, so I've written in a kind of a sketchy SOAP note of my own, but again, you can see that we're talking about a 79-year-old male who has some conditions we should note. He's taking blood pressure medication. He's taking medication for dyslipidemia. He's taking medication for prostate hypertrophy. And let's ask him some question about his falling. He tells, his chief complaint, he's here for falling. He says that he's been tripping. We ask him a little bit more. Can you tell us what's going on? He says he's bumped his head once. He says this happens about once a week. We ask him, what are the circumstances by which you fall? He says, maybe when I stand up too quickly, or maybe when he trips on a rug, so they're all things that these are potentially actionable. These are things that we can counsel the patient about. We'll work our plan as we go forward. And we also notice he's a little bit unhappy about the fact that his spouse recently died. Maybe he's got a little bit of anxiety or even some depression to think about and to speak with him about. The objective part, of course, this is all the stuff that we can measure, so we can see some important vital signs. We can also, what does he look like to us? He's pleasant. He's sitting upright in the exam table. Now, here are some things I just wanted to point out purposefully. Here are the things that we would like our students to kind of reach out for. They can ask the preceptor for example, so please tell me what his skin looks like. We have a lot of different SPs. We have even sometimes some CHS students who come in. So they're obviously not going to look 79 years old. They're not male, but we want our students to be insightful enough at least to know that skin might be an important finding. In this case, we ask our preceptor, we find that his skin's a little bit dry. There's a little bit of tenting. So he's showing some physical signs that he might be a bit dehydrated. That might be one, again, postulate or hypothesis for why, for example, he's falling. We also looked at his head because, as we said, our astute students thought, well, we better check him for any signs of trauma. In fact, they see that he's got a little bit of petechiae, some bruising on the right side of the head. They also are astute enough to know that they better do a neurologic exam. They don't see any kind of focal deficits, for example. And here's another thing that they ought to find. For a gentleman who's taking medication for prostate hypertrophy, we're not obviously asking them to do a physical exam to palpate his prostate, but we would like them to realize that they should ask their preceptor, tell me about his prostate. We find, in fact, that there's no nodularity, so our concern for his condition evolving into carcinoma, that kind of goes down. Now they need to develop a differential diagnosis. Again, we have one person here who's typing this in, but he or she is reaching out to the rest of the group. What do we think's going on? Well, we're not, medication's not out of the picture. He's taking Demulcin, and he's also taking a blood pressure medication. So let's make sure that we have at least consider that possibility. Where we did a cardiac exam, again, we asked our preceptor, we found that he's got an extra finding here, an S4. So cardiogenic syncope is not completely out of question. Depression, given the recent passing of his wife. And we've also seen some signs that seem to be worrisome for trauma. Now the question is, what's the plan? Well, the so-called get up and go test is a fairly sensitive test that you can do in your office. You just ask the patient, can you please walk to the other side of the room, get up out of the chair, and you supervise him. Obviously, you don't let him do it too quickly, but it gives you a good sense of this patient's kind of normal functionality. We also have the ability to ask our nurse, can you perform orthostatic blood pressure readings, please? Can you do a visual acuity test? I'll show you in the next slide. That's very doable. There may be some labs, and we always tell them to be sparing on this. Don't just order them because they're there and you can check a box. But for example, we think the patient may be a little dehydrated because of his tenting. It wouldn't be unreasonable to order a hematocrit, for example. Let's see if he's a bit hemoconcentrated. He's also got BPH, which gives us the suspicion that maybe a urine infection actually in people of his demographic has been known to lead to things like falling. So maybe a urine culture wouldn't be a bad lab to order. we might want to do imaging given our finding of his head trauma. We also should think about consults. As I said, we don't want him to go home to a house with a lot of junk lying around or wrinkled rugs or things. We might also, because of this slightly abnormal heart finding, want to consider the medication effect. And we might want to ask a cardiologist, for example, to give an opinion, even maybe see this patient. So as I said, our platform allows students to do selective ordering. Here, for example, and they'll run into this as well with Epic. You can order things kind of as a panel, or you can order them what I call a la carte. Now, ordering them as a panel might not be the best thing in the world, because we said we're interested in this gentleman's hematocrit. We're actually not interested, for example, whether he has nucleated red blood cells. So I'll just move on for that, but let that kind of sit in the back of your mind. We also mentioned maybe a nursing, a kind of a call out to nursing might help our efficiency a bit. So for example, we can do a drop-down menu from our ordering lab and pull up nursing. And let's say we asked our nurse to, can you please kindly check orthostatic blood pressure on this gentleman and check visual acuity. Now, good question, what's the preceptor doing in all this? Normally, our preceptors do a lot of lecturing while the students are doing their examination. In this case, we want to really emphasize that the preceptor maintain this checklist that I'm going to show you in a minute, just to make sure the students aren't neglecting to do things that are very important. We also want them to sort of encourage the students to move through the session because it's a very, it has to be a very efficient and purposeful examination. Now, I also mentioned if one of the students says, you know, I'm worried about this guy's skin, you know I'm dealing with a young SP, but I want to know, what does this guy's skin really look like? So that would be a query that would be answered with, well, it's a little tinted, it's a little dry. And depending on how efficiently the students work through this whole scenario, they can then ask about, specific questions about management or results. Again, this is as time permits. Our number one hope is to get the students through these sessions, and as the year evolves, even get to the point that they're confident enough to ask questions of their preceptor as they would their attending. So now I wanted to show you the checklist that this will look very familiar to any of the faculty who may be on the in the Zoom meeting, or any students who may be here. But we have something that's sort of a checkbox, and it kind of follows what I'm already have talked about. So when they set the stage, when they come into the room, we want to make sure that they're actually greeting the patient, that they're disinfecting their hands before they fist bump or shake hands, however, whatever the zeitgeist is, that they make sure that the patient is comfortable. They also want to set the agenda. So now this looks very familiar because they've gone through this entire essentially identical checklist throughout their first year. In fact, a lot of them did very well in their OSCEs. We want to make sure that they don't lose the talent to really bond with their patient, and then ask the permission, here's what I would like to do, Mr. Molina. I want to interview you. I want to do some focused test examination on you. I may order some labs, or I certainly want to discuss ordering labs with my attending. Would that be okay with you? And if they're doing all this correctly, and we've got them before now their forays into the clinics, they'll know they're doing okay. Now the interview and the physical exam, of course, this is the hard work. And we say this should master be out the majority of the examination. So number one, make sure you open the right chart. So are you Ramon Molina? That's what it says here. He says yes. Now, whether you're working on the computer or whether you're one of the examiners, make sure you're making good eye contact. Make sure that even though the nursing chart said falling, we want to say, my understanding, or please tell me about why you're here in your own words. We want to make sure they're going through a SOAP format. And as we've already said, the nice thing about our platform is a lot of this is being documented. So our preceptor doesn't necessarily have to perseverate too much on whether they're following the SOAP format. That's going to be documented once they have clicked the enter button. This, for example, is something that we've heard, or I've read, gets neglected too often. We have like allergies. So we want to make sure that they're really documenting every time before they pass the note on that, yes, you know, penicillin does give me a rash. No, it doesn't just cause a little stomach upset. Okay, and then I'll go through the finalizing of the EMR. So after we've done this, they're going to finish their note. They're now going to document what they think is going on. They're going to talk with their patient, for example, and they're going to say, Mr. Molina, I was concerned about this from your story. I have done a couple of focused labs. I did something called measuring your hematocrit, for example, and here was my finding. They're going to save the chart. They're then going to log out. And then what's going to happen, I'll show you what happens next. Oh, and I wanted to make sure and underline this. We always mention professionalism. I think professionalism kind of goes to an even higher level now when we're actually working with real patients and we've entered a sort of a joker card, if you like, that's the electronic medical record. We want to make sure that they're really still bonding with their patient in that exam room, whether it's focused, whether they are coming up with a plan, whatever. They still need to make sure that that medical art remains in place. So at this point, they've finished their note. They have ordered their targeted labs and even gotten maybe a consult or two. At this point, they close the record. They so-called sign out. They don't have medical licenses, so they don't get to sign this thing into the real hospital system. But this will allow them to then reopen the record and review what they have. And here's what we've designed as feedback for the students. So for example, I mentioned he was a little dry, and I thought, why not order hematocrit? Well, what they do, well, they'll see, for example, if they follow this code down here. So this code was number 2. It was an appropriate lab. You know, we decided on our faculty review of this case that this was an appropriate lab. So we would score them a 1. They ordered an appropriate lab. They requested it. They found, in fact, that that lab is a little bit abnormal. The normal reference is 52 for our cohort, our patient population. His was 55. So he is a little bit hemoconcentrated. So that's an important finding. We also mentioned that given his history of BPH and his falling, we might want to think about could he have an underlying infection like a urinary tract infection. You can see that, in fact, we ordered this lab. It was absolutely appropriate to order. It was negative, but we still credited the student. So in this case, the student got in the number 2. So this was appropriate and requested. So student got a point. Asking the nurse to do the orthostasis, that was absolutely appropriate. So this person got a point. We asked for some consult. We mentioned his S4 heart sound. So we require a lot of things. We want to make sure that they not only ask for this consult, but we also want them to write a note to the consultant. So don't just say, Mr. Cardiologist, please come. We want to make sure that we understand, he understands or she understands that we have a 79-year-old patient who's on medication X, Y, and Z, is falling. We're concerned about maybe a cardiologic etiology. Can you take a look at this patient? Would you recommend so-and-so or any change in medication? Okay. So now ultimately we have all of this information in hand, and our next step is, of course, we're back in the room to talk with our patient. We all as a team have basically been following this person. So we want to say, Mr. Molina, I understand your concern for being here. Given my findings on examination and my limited labs, I'm thinking this may be going on. Here are my recommendations. So our students will, of course, document this in an addendum. So they're learning, for example, the importance of correct documentation. So we do call this an addendum, and they will document this at the end of their note. So we noticed a few things from our lab, for example, and our physical exam and our nursing exam. So our updated plan, remember, the last time we were thinking we wanted to order this, this, and this to help us kind of decide what to tell our patient and how to manage our patient. So our updated plan will document everything that we then spoke with about the patient. The fact that we ordered a site consult because we were a little bit concerned on further discussion that maybe he is a little anxious and depressed, and maybe that, the reason being his wife, maybe that is part to blame for his recent falling. We also want a home health consult to come and check out his living situation, make sure he doesn't have a lot of loose lying rugs and things that will trip him. And then we finally will come up with our final plan. We want to reassess this patient in a month. Now, like I said earlier, I think the different attendings are going to vary in how much planning they want the students to document necessarily, certainly in the EMR. But we would like to get the students to the point that at least they can come up with a solid note for the patient, they can come up with a good plan, and they can demonstrate that they're able to discuss with the patient their plan and their discussion with their attending. So in conclusion, I hope I've convinced you that the EMR is just going to keep playing a more and more pronounced role in patient care, and really that our MS3 preceptors anticipate a lot of use in EMR for our students, and that fortunately, our students seem to favor adding an EMR to medical skills, and from our kind of limited interactions with the students at this point, we've seen real progress and real excitement in their faces as they work through these scenarios. We think they're more realistic. We think they're facilitating more student engagement. And we think they're probably, the way that we've designed our system, we think can probably enhance some of the assessment and performances through our faculty. And we've also, kind of as a parting note, since I'm speaking to the College of Pharmacy, we've already reached out and I've begun speaking with Dr. Malhotra, and we've talked with Dr. Menti about maybe using this kind of a format as a sort of an interprofessional education exercise where we can all talk together and think about a good scenario that would involve, again, a standardized patient and some kind of an exchange with the pharmacy students that would allow us to work with our patient scenarios. So I wanted to just end by thanking everyone. It's been a lot of fun. Dr. Puglisi, of course, designed our platform. Dr. Alkayat has been, and Dr. Baranoff, unfortunately, I still don't have a good picture of her, but they've all been instrumental in working us all into medical skills. We've had students, these students are now, I believe, in their 4th year. This student is, I don't want to pin where they all are, but it's really been fun working with students. These are our current students, and they've been adding a lot to the conversation. And at this point, I've kind of run to the very end of my talk, but I was really hoping to get some questions or comments if you just want to unmute yourself and shout them out, I'd really appreciate it. And I want to thank you all very much for your time.
Thank you, Dr. DiSibio. What a wonderful conversation you've started. Thank you very much. We're very, very glad that you're also thinking of extending this to pharmacy. I'd like to start inviting questions. In the chat, we had questions from Meredith and Tura. I also saw President Chung perhaps was wanting to weigh in. So I'd like to I'd invite President Chung to say a few words at this time.
I just want to say thank you to Dr. DiSibio for a very, very well-prepared presentation, and then take us, deep into the training of medical skill using electronic health record, and then add an additional dimension and a sense of realism in developing their medical skill. Is so important that they have a near life practice, and training environment. I think the questions I have is that, as we all know, one of the component of social accountability is to teach our students to deliver cost-effective medicine. So is there any features that you plan to add as part of the electronic record experience that our students have a sense, the tests and then the procedures they are planned to contemplate will have some kind of a dollar sign signal, so they understand, well, how much does it cost? Would the patient be affordable, able to afford the treatment? And then how I make a determination what is best for the patient.
Well, thank you. That's a very interesting question. I think really what I was hoping to emphasize was, of course, using LabVIEW, as Dr. Puglisi has. The nice thing is we can adapt so many different elements into that final calculation, right? I mean,
Right.
The cost of, depending on, ultimately the sky's the limit for however complex we want to make these cases, whether we're talking about targeted therapy for cancer and, whether it's covered by a patient's health plan, for example. There's a lot of great questions that we could, I feel like our platform allows us so much flexibility to add almost anything into this that we're imagining. We just haven't gotten there, but it's a great question, Dr. Chung. What do you think, Dr. Puglisi?
Yeah, we can put another variable that implies the cost of the treatment. So when they go to the lab tab, they have the lab. We can have a first approach like low cost, medium cost, high cost. So they could choose which one is the best for them. But as you mentioned, it's very versatile, the platform that we are using, so we can add all those things. And also you mentioned the version for the farm students. We already have talked with Dr. Welly Mente and Dr. Mahutra. The platform for them will be a little bit different from our students to begin, because the objective of the farm students is to detect some mistakes on the prescription. And the objective of our side is that our students do the right prescription. So we are going to, so we can have two separate entities that on the front side will be the same, but inside will be different. That we want to check that. That's my only comment.
Dr. Puglisi, I actually want to come in. That's very exciting because, this is a wonderful platform. We can extend this in the direction of interprofessional education, as you were mentioning. So I'd like to remind everyone that in spring, we held an interprofessional education grand round to teach our students the art of management for clinical stroke. The reason I bring that up is because pharmacists are not only limited to sort of looking at the drug side, but there is a whole entire subject. I think President Chung, probably this is close to his heart, pharmacoeconomics, and that can be incorporated into this platform. And that is, I know that we surveyed our College of Medicine students and faculty when we did that activity. We had an element of pharmacoeconomics in helping them decide which drugs to choose, for example, for stroke management. And we also told them about how to calculate risk and benefit analysis. Dr. Jeffrey Nahira from our department did that. I just wanted to quickly share that could be another angle. It could really enrich, like you were saying, Dr. Puglisi. And very quickly, I also want to share that, another big, huge opportunity I'm excited about, as you can tell, that I think that can be built into here would be the social determinants of care. So I think there is a lot of opportunity to build in some of that structure, especially in the current ongoing conversation in the country, to bring in aspects of, say, various social determinants of care, to bring in population, differences like pharmacogenomics, or maybe how that would affect treatment. We have time for a couple of more questions, if everyone can stay for a few more minutes. I'm sorry for the delay. So we can take a couple more questions. I can read the questions, or Meredith, if you're still here, Tura, if you're still here.
I'm still here. I didn't have a question. I just had a correction that we had 2 to 3 students rather than 3 to 4 students per group in each room. Okay. And that worked better because each student had a defined role and they rotated roles each block. And Meredith's question was, the recent one that he just put in about the lab test available, it would be easier to put them in 3s. Actually, Pepe has created some of the labs to be in panels and in sets, and the student has an option to choose that certain set or panel, or they can choose individual labs depending on, the case. Right. And we can always go, and it's very flexible the way that Pepe has created it, that we can always go back and edit the labs in each system and each case as we go along.
Yeah, I see Dr. Goodwin had another comment about lab testing as a sort of a cluster or individual. So, and by the way, these are all great. These are all great comments by practitioners who've used the EMR. So a lot of what Dr. Puglisi and I have, and Dr. Al-Kayed, and even Dr. Baranoff have done is just kind of use our best guess for what we want this thing to look like. So, I am all open for anyone's comments as far as, what it really looks like, or what problems we might design to put in, or if anyone wants to contribute cases. And, I think this is a good lab to order. I think they might order this, which is an inappropriate lab. So there's a lot of room for development, is the bottom line.
And just going back to billing, I think initially when we created the EMR last year, we talked about including the ICD-10 code in the program, but we were not sure if that would be possible, if there would be any impact on this. But it is one of the projects down the line for Pepe to include the ICD-10 code.
Yeah, the ICD-10 codes, we could do that, but that every year they have a new code. Now we have IDC, I don't know which the version. But most importantly is that this program that we created with Dr. DiSibio is the only one that provides feedback to the students.
Yes.
The other schools, they
Can you vote because we don't have all the numbers here.
So, this is a different process, and for us, actually, it's more we provide the recommendation, and we're not like making this is the final decision or whatever.
I didn't hear.
I think that's saying somehow, but I don't see him in the group.
Yeah, the thing is that the other schools, what they do, they have a version of EPIC and make the students to try that. And EPIC does not provide the feedback that we said. This lab was not required. This lab you should have ordered it and you didn't. So that's the beauty of this platform. That after the interview, the student received a report of what he did and what was good, what was bad, and what was missing. For example, if the student missed to check the allergies, there is a message, you forgot to check allergies.
Right.
When we finish with the farm version, we'll have a checkbox that said, you forgot to consolidate the medication. So that will make, that feature will make us separate from the rest.
Yeah, I mean, I'll add one thing. I mean, the students do go through something called SCC, which is kind of an introduction to EMR. And basically what it entails is that they get a password. And I think the students and I may have gotten a little false sense of security that by the time they're in the clinic, they're all ready to start using EMR. I think it's kind of a false sense of security because that's all it really does is it allows you into the system. But, you know, and then it gives you a little bit of time to kind of play on the thing and click a couple of tabs. But what we're hoping is that by designing something that's very simple in principle, but very adaptable and can, you know, over time potentially become more complex or less so, depending on what you want to do with it. It'll give more flexibility for actual teaching. And since we're starting the students in the second year and their momentum's building up before they get into the actual clinic, they'll be a little bit more ready to go. I mean, they'll still need that final training to get their password or whatever, but they'll be more sophisticated when they walk in the door, I hope.
Thank you, Dr. DiSibio. Thank you, everyone. I think at this time we're 10 minutes over time. So out of respect for everyone's time, I'd like to thank you for being here. A quick reminder that this session was being recorded and we plan to share the recorded session with all CNU. Also, many, many thanks to President Chung for taking out time. I know how incredibly busy he is. So for taking out time to be here today. Many thanks to Dr. Yang for her amazing, wonderful support in getting this going. And many thanks to Samantha Webster for actually organizing everything. Very soon we will send out an email about the next one up. That is actually Dr. Puglisi himself will be talking about a slightly different angle about his work in a few weeks. And then we'll have a session.
Really?
You promised me. Then we'll have a session with Dr. Vinyl, and we'll be reinstituting our research workshops within the next month. We'll also speak quickly about some teaching awards that I'm working with Dr. Yang to put together. So lots of exciting stuff coming in the virtual platforms.
Thank you, Dr. Malhotra. Have a great rest of the day yourself. Take care, everyone.
Please take care, everyone.
Thank you.
Thanks, Dr. Chung. Take care. Have a good rest of the day.